Welcome and thank you for joining us for our SIH Second Act program today. We are going to have our presentation listed in our bulletin, the newsletter that you've received, on the 5 R's of controlled substance safety today. Kayla is with me today, running everything. We greatly appreciate her. And Tracy is having a day out of the office. So anyone who's new and you haven't met us all, I am Kelly Corner, the Health Education Coordinator. And Kayla Lazorchek is one who runs everything for us and keeps us all on task. So we appreciate that. All right. If you do have any questions as we go through today's presentation, remember to scroll down on your screen, and then there'll be a section where you can just click and type in any questions you may have. So we appreciate those. Kayla will give those to us at the end of the presentation to cover. Upcoming events, things we're going to do right after Thanksgiving is our class on the Synvisc injection that you can get, different means of keeping from having pain in your joints. That'll be the Tuesday afterwards, so I want you to remember that. And then it is still Medicare open enrollment. Millie is working very diligently, meeting with everybody she can. So if you have a question, you can feel free to give us a quick call. Her appointments are full at the moment, but I'm sure Kayla has some kind of a waiting list going for us, right? She's going to shake her head for me. All right. So I do have the privilege today of introducing our speaker. This is Dr. Jodi Swain, and she has her doctorate in nursing practice, and she is going to go over with us dealing with controlled substances. This is actually from her dissertation for her doctorate, so she is well versed and very up to date in the information on this topic. So I'm going to introduce you and go right ahead, Dr. Swain.
Thank you so much, Kelly. I will have Kayla pull up our first slide, and I did label the 5 R's of controlled medication safety. And what I'd like to do is be able to present from a systems approach, kind of talking a little bit about some of the laws, some of the history that's shaped what we do with our medications, and why we're where we're at in medications and addiction issues and what we're seeing nationally. And also, how does that apply to you personally? What are some things that you can do and make sure that you are safe and your family members are safe? Next slide, please, Kayla. My disclosures. My first disclosure is I do live in the state of Michigan. A lot of these issues are national. A lot of these programs are national, and or states have been given the freedom to do their own programs around controlled substances as a requirement from national laws. And my second disclosure is that your coordinator has been coordinating my life all of my life. Either I am Kelly's younger sister. I won't disclose how much younger, but just in case you're wondering where the connection comes from Michigan to Southern Illinois, I'll help tie those together for you. So our next slide, please. How did we get here? I gave some thought as I was going through the slides this morning, and I made an assumption, and I hate to make those kind of assumptions. I've been a registered nurse for 30 years. And yes, they let you in when you're 12. I'll just say that. It's not true. And if you add that math together, that's also not true. But controlled substances, I feel like I need to define. And a controlled substance is a pharmacological terminology, and it comes from how do you obtain it. So if it is controlled, there's a couple things. One is it can only be obtained through prescription, at least in the legal way. And a prescription has to come from someone who has a prescriptive authority. They can be, you know, a physician, NP, a PA, a CNS, nurse anesthetist, midwife, all those positions, people who have a prescriptive authority. They get special licenses, they can write prescriptions. They also get an additional license that has a DEA number in, and it literally is from the Drug Enforcement Agency. It allows them, because they have the degree that they have, to write prescriptions that are controlled. Controlled medications are those things that are narcotics, stimulants, benzodiazepines, sleeping medicines. Those are medications that are more likely than not to be addictive and or sought after. and have some legal ramifications with them. So taking a step back, why are they controlled? You know, they're controlled because if they are mishandled, it could lead to a lot of issues. The other thing that is in the controls is how you have to pick them up. So this is some of those new laws that require a driver's license for you to be scanned in, and it goes into systems that are called a PDMP, which is prescription medication tracking. And every single state has their own PDMP. So for me to tell you, we're going to talk about controlled medication safety, I thought I should take a step back and talk about really what a controlled medication is. 5 R's of controlled meds is actually not trademarked yet, but I think I should. The steps that any good program and or system should have in place to make sure that controlled meds are being handled as safely as possible. We can go to the next slide, Kayla. So how did we get there? Actually, I'm sorry, please step back one. How did we get here? There's so many influential things that happened in the United States that affected our controlled medication history, our controlled medication handling. So the American Pain Association did advocate for pain as the fifth vital sign. And I'll let you know that the APS, all right, friends, I'll just say right now, if you've been watching Netflix Dope Sick, that's exactly how it happened. So Michael Keaton did a fine job in that. It's actually a book. The book is phenomenal. It doesn't have the rich storylines that go with it that they created, but it does give a very good historical piece of information. The physician that they represent in there, called Dr. Van Zee, I actually did read a couple of his research articles and put them in my dissertation. We got here from APS. APS, yes, was created by companies like the Sacklers that stood up and wanted people to start prescribing more of their medications. So that started in 96. In 2001, it caught on to the point that Joint Commission said, oh, we should be advocating for this fifth vital sign. We're going to go into hospitals and we're going to say, did you medicate someone for pain? Did you ask them what their 1 through 10 was, what it meant to them, what their level of pain was, what they could tolerate? If you medicated them, did their level change? Did you document it? And if you didn't do all that, they didn't let you be reimbursed from the Centers for Medicaid and Medicare. So there was a lot of pressure to adopt this. There was a lot of changing of culture around pain medicine, which wasn't the I'm going to have surgery, I'm going to experience pain, went to I had surgery and they should be medicating me to the hilt so that I experience no pain. There was a large shift in that. There was the measurement of patient satisfaction and performance for providers, as well as reimbursements, all tied around how generous you were with pain medicine and how much people were comfortable. And then also there's always been an underlying dismissive attitude towards addiction, whether it's alcohol use disorder, substance use disorder, that people were making moral decisions, that they had decided, you know, today I'm going to wake up and, you know, develop a heroin addiction, you know, that they could just quit. And I want to be able to share a little bit of that information with you guys and what really happens physiologically to someone with addiction. And Kayla, we can move to that next slide now. I pulled this right out of a presentation that we've made numerous times, and as you'll see with our friend, we do have, you know, Rush Limbaugh as the poster child there. OxyContin really brought addiction to the forefront. It created a whole new generation of people who struggled with addiction. When OxyContin began to be reined in, then people changed to heroin. Heroin became harder to find. People changed to fentanyl. Fentanyl overdoses are really the most common overdosing that we're having right now. Historically, the Stark Law is something that was developed in about 1989, and the Stark Law um, was created to bring physicians in line, to bring drug companies in line with self-referrals and with co-ownership. So you had to start making all these disclosures. So if you were a physician who did orthopedic surgery and you did these joint replacements and joint injections and things like that, you could not refer patients to the rehab that you partially owned. So the government did start stepping in on that. That was in the late 80s. That also gave rise to something called the Sunshine Act or the Sunshine Laws. Those were put in place a little bit beforehand, but they didn't really get a lot of leverage until again later in the 80s and 90s. And the Sunshine Law or Sunshine Act actually enforced transparency, and the transparency was around any motivation that offices received, any trips a physician got, any perks, any meals, anything. There is still Sunshine Law or Sunshine Act things in place. So let's say Kelly had talked about Synavist injections. Well, if the rep from the Synavist company went into Dr. Smith's office and left them with 6 sample injections of Synavist, whatever the average market cost of that medication is, whatever doctor signed for those samples to be left there, that would go into a website and you could look it up and you could see, again, Dr. Smith received $40,000 in medication for his office to give to patients. That is the part of the transparency. Well, those two pieces in place took away a little of the motivation from physicians to work very closely within their own motives or own business models, as well as being able to be freed up to take things from pharmaceutical companies that perhaps they would have to report. And it gave rise more to direct-to-consumer advertising. The United States is one of only 2 nations that advertises medications to the public. So every commercial that you hear that starts with "ask your doctor about" is directly from the fallout of these 2 laws. Now, the other reason is that in the 90s, these aging baby boomers, hello, we know who we are, or darn close to it, they started taking more interest in their health. So if you think about our parents, they pretty much did whatever a physician said. You know, they say go stand on your head 3 times a day in a corner, and this is what is going to be best for your health. That's what they did. They didn't ask a lot of questions. They didn't seek out a lot of information. Didn't do their own layperson research. But as the boomers aged, the internet became more available. They started to see a big rise in people taking an interest in their health. If I have a hemoglobin A1C that is X, what does that mean? If I drop it by that many points, what does that mean? There was a much more of a involvement and in self motivation around health. That made the difference that in 93, about $166 million were spent on direct to consumer advertising. That went up to 4.5 billion by 2005. And now it is 40% of any pharmacy or big pharma companies budget is they spend 40% of it, not on creating new drugs, not on trying to give things away, on direct to consumer advertising. And all of that does impact how we get our controlled substances and what they look like, and the rise in that advertising. So just a bit of history for you that can be kind of discerning. We can go to the next slide, Gayla. On this slide, what I'd really like to talk about is when we focus on why people have trouble with addiction. I think the slide to the left really brings home the point that it is not just I'm drinking too much coffee. I think I'll stop drinking coffee tomorrow, and or much larger uh, substances. And coffee does rewire your brain as well. That's my addiction of choice. But the bigger drugs actually rewire your brain to the point that it is physiological. It is not just psychological. You're not just making a decision to stop or do something. You are physically driven to need to do that to keep functioning. And that can happen really rapidly. It can happen in as little as 3 doses of a medication. It can happen in less than a week, that it becomes a lack of, I think I'll take this for pain, to a, if I don't physically do this, I am in pain. Addicts have expressed the feeling of withdrawal, that it feels like their bones are breaking through their skin if they don't get what they need. And I can only imagine what that level of pain must feel like. Kayla, if you could, I have an excellent, really short YouTube video on here that's just like 3 minutes long that discusses those brain changes. And if we could launch that, I think everybody would find it super interesting. Are we having luck? Kayla, if we're not having luck, it would be okay for me. We just send this out to the people, and they can take a look
I'm
at it
sorry.
later.
On my screen it was working, so let me
Yeah, I'm not
try it
seeing it.
again. Okay, give me 1 second.
Absolutely.
All right, let me know if it's gonna play now.
Terrific.
Good.
And sound?
We do need to have sound if we can get that, Kayla.
Okay. All right, third time's the charm, they say.
There we go.
The human brain is hardwired to seek pleasure. That's one of its jobs. Our brains are pretty much a gigantic network of neurons that try to school us into learning which behaviors are worthwhile and which ones aren't on a daily basis. And today, as countless people get hooked on things like drugs, technology, or social media, companies have actually hacked this system. From junk food to fast cars, businesses know how to promote products that are built for pleasure, even if they can harm you. Even doctors with good intentions sometimes prescribe certain painkillers that can send brains over the edge in a pleasure-driven loop of destructive behavior. But what actually happens to the brain of a person with addiction? It can start with the limbic system, also known as the reward center, unleashing the pleasurable chemical dopamine when the brain fulfills its craving. Over time, the recurring shot of dopamine can turn a compulsion into an addiction. The brain starts thinking it must have more of the drug or behavior. As the addictive behavior takes hold, the brain will rewire itself, making it harder to stop the destructive behavior. And if you're battling addiction, you are not alone. There are ways to get off this runaway train. One first step may be understanding how you got here, how your brain learned to reward this behavior. But the most important step is realizing there are ways out. Anyone who is suffering from an addiction should call your area's addiction hotline or contact the National Helpline from the Substance Abuse and Mental Health Services at 1-800-662-HELP and get control of your addiction and your brain. Hey, thanks.
There we go. I love that short video just because it does give nod to the fact that there's multiple things that you can be addicted to, and SAMHSA is really just the greatest resource for anything that's going on locally. And we can flip to the next slide. So I have in here, there we go, a successful controlled medication program has to have numerous steps to it. We have to recognize when someone is struggling, rescue people who are at risk for ending their lives because of their addiction, recover people who have addiction issues, reduce the amount of medication that is available to start developing those addictions, and overall remove them from circulation. So that's what I need to coin by there. I need to get a little registered on that, because that is really the basis of all the work that I have done, both in my doctorate and in my employment. So let me share with you what some of those steps would look like. So our next slide is recognition. Now, there's a lot of governing bodies in medicine. Every specialty and subspecialty has their own group, whether it's dentist, orthopods, addiction specialists, primary care, surgeons, everybody has their own subgroup. And excuse me, Glad that was virtual because you can't sneeze in 2021. The universal screening would be the answer to this, and the SAMHSA agrees that everyone should be being asked about substance use disorder questions. Now, a few of those screening questions I have at the top. In the last year, have you used more drugs or alcohol than you were meant to? Have you or your partners or parents had issues with substance use? Have you ever felt like you needed to cut down? Those are some sub questions out of like 3 of the most popular screening tools. There's also the information gathering in healthcare. Information gathering is not really a screening tool. It gives you the basis, like, oh, do you use alcohol? Yes, you do. Well, how many drinks do you drink a day, a week, a month? Those kind of questions. That's gathering. It isn't a validated and verified screening tool that you could come back to and say, if X, then Y. If they say they drink more than 3 drinks a day, then you have to, they take personal interpretation. And when you have actual screening tools, it automatically, if you pop yes to this question, we need to do an intervention. Now, recognition isn't solely the job of healthcare professionals. And yes, we need to do a better job. We're stepping into mental health, asking about anxiety and depression, being aware of people's mental health. Substance use disorder is a mental health disorder. It actually is recognized from the DSM criteria as something that is not just a moral choice, but an actual mental and physiological issue. And healthcare is getting better at that. I mean, if you can remember a time when we used to not have bariatric programs because they were fat because it was their choice to be fat. They just needed to stop eating. That got really recognized as a physiological issue. Same addiction issue, rewiring of the brain. You got to have it, and people have worked with changing those behaviors, medications, and surgeries, and we're now more respectful of people who struggle with that as their addiction. Healthcare has a ways to go. We always do, but personal observations can also be added to that. So in personal observations, you probably recognize when someone is struggling. These are people who are actually struggling with these 5 issues on the slide. It's part of the DSM criteria for how do you know how much their addiction is affecting their life. Are they having problems at school or work? They're not showing up. They're maybe stealing. They're having things like that. Are they having physical health issues? Your person addicted to alcohol will have varicosities and be vomiting blood quite often. They'll have liver issues. The whites of their eyes will be yellow. You'll see things like that. Physical health issues. The person struggling with a substance use disorder, they have unexplained weight loss. They often, if it's a methamphetamine addiction, they'll have the pock marks on them from picking while they're having hallucinations. If it's someone with a substance use disorder, sometimes you can even see, poor teeth. They have physical issues from their addiction. Neglected appearance, again, you see people who are disheveled, they don't do well in the morning, they're wearing the same clothes, they're not physically taking care of themselves. Changes in behavior, a star employee starts sloughing off, or a star employee was a star employee because they kept volunteering to pick up a ton of extra shifts all the time. Well, that was just to feed their addiction, and now they can't keep up with it, and you're seeing these changes in their behavior. And the big one is always the money issues. If they're jetting off to Vegas every other weekend, it's probably not a good sign. There's something more going on like that. So recognition can both be done by professionals and it can be done by us with our family members and our lay people. And you were right, Kayla. I was wrapping that one up. It's all good. I'd like to talk in this particular slide, the concern about co-prescriptions. So we're recognizing that somebody has an issue, and this is kind of part of that the rescue. What are we going to need to rescue them from? And we'll get into the med that does it for it. But I had mentioned in the flyer, what can people become addicted to? And I had mentioned too, what are controlled substances? So when you talk about opioids and pain medications, I think people are pretty familiar. If we've gotten to this stage of our life, we've had Tylenol with codeine, we've had a Norco, we've had hydrocodone, maybe we've even had Oxycontin prescribed for us at some point. Injectable morphine, injectable Demerol, all those kind of things when you're in the hospital. Those are the controlled pills of the previous ones that I mentioned. are going to affect your opioid receptors in your brain. What we call in the healthcare the triangle of death are opioids mixed with benzodiazepines or Z meds. And what I mean by triangle of death is literally these three meds together cause more overdosing and more depression of the respiratory system, so that people die in their sleep than any other combo that is out there. Benzodiazepines are anxiety medicines. They're taken for sometimes depression, anxiety. They have a very calming effect. Your Xerox, Xanax, Valium, Ativan, they're sometimes given for sleep. Restoril, Halcion. Klonopin is a very good, almost mix between anxiety and depression medication. Those medications bind to the same areas that opioids do in the brain, and they have a very calming effect. They calm your heart rate, they bring it down. Your respiratory rate, they also bring down. If you prescribe those with opioids, it can suppress the respiratory drive to the point that you stop breathing. If you combine those with your Z meds, so you're taking your Ambien, Sonata, Lunesta, Zolpidem, those meds right there, those three in combination should never be prescribed in combination. So if you know anyone on those, and this is such a common practice because you get your pain medicine from your bone doctor and you get your anxiety medicine from your primary care doctor, and maybe you're getting a sleep med from a psych doctor because you're having trouble. And so there's that disjointed combination of prescribers not knowing that you're on other meds. And the number one risk for health issues around medications is med to med or drug to drug interactions. And when it comes to controls, it is seen in sudden death. You take your Xanax because you're anxious because you had your hip replaced, and you take your pain medicine because you want to sleep, but you're just not sleeping well, and you take an Ambien and you do not wake up the next day. So we really don't like to see those in combination. And quite often, this is a pharmacist check. They will be the ones that you go to the pharmacy and they'll say, hey, this is not a good idea. And this is not, when we talk about addiction issues, this is not your 25-year-old scrounging around in somebody's pharmacy cabinet. This is prescriptions come about by providers taking care of issues that you're complaining about, trying to resolve things, and not realizing the combinations that are being given. So this is your 75-year-old who recently had surgery. This isn't like, oh, those darn kids. No, this is reality of, I better open my own med cupboard and see what I have in there. So those high risk prescriptions that all go together, check on anybody. If you have your parents, if you're sandwiched, and or your other loved ones, to make sure those co-prescriptions don't exist. There are best practices that I do want to mention, and best practices by specialty are things that are newer. They've come around in the last, 2 to 5 years, where if you have an orthopod and you have a certain procedure, you have your knee replaced, their group will say a knee replacement really only requires this number of pain pills. So you're not going to get 90 Norco with a refill anymore. You're going to get 15 Norco, and then you're going to get a case manager that calls you to see how your pain is being handled at home to discern if maybe you need 10 more. There is not quite as much freedom in prescribing meds as they had before, which is good because it means you're only getting what you need. You're medicating yourself for pain. You don't have any leftovers at your house, which is when we talk about reduction and removals. This is part of reduction. And there's less meds that you're going to have to go donate, get rid of, get out of your house somehow because you just didn't need them. So we're not under prescribing, we're appropriately prescribing now. And Kayla, we can pop to that next one. How do we rescue people who have overdosed on opioids? Narcan is it. There is no other. Narcan is an inhalant. It is also given as an injection, but that's more like paramedics and medical people to do. Narcan binds where we'd seen in the video, those kind of pokey looking things, those are neurons. What Narcan does, and I have a picture of this in a couple slides, is it just blocks on those neurons and it knocks everything off. So it binds with everything that is an opioid on your neuron, pulls it out of your system. Narcan is very effective for prescription opioids. It does nothing for benzodiazepines and Z drugs, but if you're taking that combination, it will pull the opioids out, which will hopefully stimulate the respiratory system again. When it comes to street drugs like heroin and fentanyl, sometimes they are so potent, which is why so many people die from them, it can take 2 or 3 doses of Narcan to knock that off, knock it off, and knock it off, and then start the respiratory system again. When we use Narcan in the real world, oh, people are mad. They're mad. They're not mad you saved their life, maybe. They're mad because they were having the best experience. And like, they took the stuff usually to fulfill a need. And when you pulled all of that out of their system, they don't wake up happy. They don't thank you for saving their lives. They usually wake up swinging, and you had best be limber. You might need to make a move. So that does not happen with our older population with accidental combinations, things like that. They're very grateful. But for those who are struggling with addiction, they're not happy that you took away that feeling, because that's kind of what they were looking for. So just a word of warning on that. We can go on to cheerily the next slide. This is a picture I'm talking about in the world of recovery. Opioid use medications, we'll talk about in a minute. The far neuron over to the right-hand side that has that full block on it, that's naltrexone, that is Narcan. And what it does is it completely blocks things. In recovery, I'll come back to our slide in a minute, the 12-step programs are generally abstinence-based. And they're really brought about by the morality concept. The idea that you should stop, we can give you some steps, you need to work through these, you need to recognize why you're using the meds, and it is all asking for you, a lot of times using a higher power in these programs to aid you to just walk through and do this through abstinence. And I think we've looked at enough with the brain and having these open neuroreceptors. As you become more addicted, your brain actually grows more receptors, which is why you need more and more and more. And so now we're asking this damaged brain that has all these extra receptors in it to just stop. Morally, you should be able to do that. Now, if I'm showing you a little bit of my cards on how I feel about that, it's because they don't work very well. People generally go through these and have a lot of relapsing. Kayla, the next line on there also has medications. So medications for opioid use disorder, actually go back. It's just that line right there, medication for the opioid use. Those are the 2 meds over to your right. And methadone is one of them. And everybody's heard about methadone clinics. They're very highly regulated. They bind completely. They replace it. They are literally a medication that replaces your medication. They are an opioid. They're not an agonist. They absolutely fill that need, and they heal your brain by filling the need with something that you can't overdose on, because they are this full block of your neurons. So if you're taking methadone and you take heroin, you get nothing. You get absolutely no high whatsoever. You get no reward, none of that feeling, none of that rush, the high, the serotonin, the dopamine. You get nothing, because there's nowhere on your neuron for it to bind. Now, the other med is buprenorphine, and buprenorphine is a mix between naloxone and Suboxone buprenorphine. And so it's a partial agonist antagonist. And so if you did take heroin and you were on buprenorphine, you might get a little bump, but you're going to get nothing like it was before. And it really takes care of that reward center. Now, medications for opioid use disorder, we like to call them that. We don't like to call it medication-assisted treatment, because really the medicine is the treatment. So you can go through a path of doing your therapies and things. When you do MOUD, or you do those courses, they do require for you to do some self insight, some work. Try to take care of the baggage, repairing the relationships. Why are you doing the things that you're doing? All of that. But in combination, this type of treatment can be highly successful. Yes, sometimes people step off and back, but compared to abstinence, the recovery rate is anywhere from 50 to 75% more successful. So it's really significant. And that does require some extra training, and it does require physicians to understand what it is that they're medicating for. People get prescriptions. They can induce at home. They can take it. It isn't as restrictive as methadone, where you have to go same clinic, same day, every time. If you get a flat tire on the way, boom, you're done. They kick you out for a week. You got to come back in. So it doesn't have that structure. They're a little bit more realistic. So I truly believe we should treat addiction like we treat diabetes or heart disease. And you don't kick somebody out of a clinic if they stop taking their insulin, or if they get admitted to the hospital with diabetic ketoacidosis because they had too much sugar and didn't take care of themselves. It's a disease. People have recidivism from those diseases. They should be allowed to have some issues and get a clean slate and get to start over from this physical addiction as well. So that's just my soapbox. I'll step off for just a moment and keep sharing. We can go to the next one. All of these are medications for opioid use disorder, and those are the names for them: the naloxone, the Suboxone. They're kind of a little fun to say. It's not a fun disease, but it's a fun one to say. Buprenorphine, Sublocade, naltrexone, and Vivitrol. Vivitrol is a great med because it is an injectable medication, and so is the naltrexone. But what we really like Vivitrol for is that it is a long-term medication for alcohol use disorder. So it blocks those receptors for people who are overusing alcohol, and it can be given as an injection every 30 days. So you get a shot and you don't have the cravings. And if you do drink, doesn't do anything for you again. So that one is a very popular medication for people who've gone through and dealt with a lot of their baggage on why they're doing what they're doing, but they still need something to help keep their brain blocked and healed. And they're just all great options for treating use disorders. We can step to the next slide. So what about the reductions? I had alluded to them 2 or 3 times already. Those new standards of care and clinical guidelines for specialties, even orthodontists and oral surgeons have this stuff now. So if you're pulling wisdom teeth, the kids shouldn't be coming home with 30 days worth of a narcotic pain reliever for having teeth pulled. They're probably 5 or 10 at the very, very most. A lot of them are getting 3. And they do fine. I mean, dry socket aside or any of that kind of stuff, they're really discouraging this overprescribing. And there's also these mandatory checks prior to prescribing. This is another one of those national programs, and I had used the initials PDPM before. That is what you guys have in Illinois. You don't have any special name for it. In Michigan, we call it MAPS. It's a Michigan assisted prescribing system. So let's say that someone is struggling with some overuse and they're doing some doctor shopping or doctor hopping. Any prescription that is in their name, that's why we have to slide our driver's licenses to pick them up anymore. It requires that identification. That is statewide. All the states are not quite connected yet. They're working on making it so that all states are connected. So even if you are somebody who is in 2 different states, you're in Michigan and then the weather turns and you go to Florida, we're getting those systems to be able to talk to each other. So there is a prescription monitoring program. I did cut and paste that over for you guys for Illinois, and that is in place to try to keep this from happening. We're really working with providers for less accurate or less generosity in prescribing because it's unneeded. And that's not just based on we don't want the meds out there. They did exhaustive research on, hey, you got a new hip. How many pain pills did you take? And they met with patient after patient after patient and doctor after doctor after doctor and did like a meta-analysis across these things going, you know, when someone gets a new hip, they've been in so much pain that the new hip only causes pain for this many days. They get up, they do their therapies, they do all that. They're on average taking 10 pills, 15 pills, you know, and we're prescribing them 90. We don't need to do that. Let's prescribe 15 and revisit it. Let's prescribe 30 and revisit it. So that's where those care guidelines are coming from. It's not, well, you know, we were way to the side and did way too much, so we're just going to stop. That's not what that is about. It's about being accurate with the amount that we are prescribing. So that would be reduction. And Kayla, I think we have removal. This is one that always garners a lot of attention and a lot of interest. Is, you know, when you open your cupboard, they might be from, you know, 2002, but you probably got some Norco kind of tucked back in there just in case. And that is one of the portals of entry for younger generations to get into overusing opioids. Is they go shopping, and they go shopping in their parents' med cabinets, and they go shopping in their grandparents' med cabinets. So we need to remove those medications. Frankly, they're not going to be quite as effective if you've been squirreling them away as long as you have. So, you know, don't hang on to them for another 12 years, because if you haven't needed them in 12 years, you're not going to need them now. And you can appropriately get what you need if you appropriately need it. So how do we get rid of those? Now for this slide, and it's not as crystal clear as I would like it to be, the DEA, if you just literally put in DEA and med removal, that will take you to this site where it'll say, do you want to get rid of, you know, controlled substances? And you put in your zip code. And when you put your zip code in, it tells you every single place that'll take your medications back all the time. So that's if you go into jails and pharmacies and sometimes hospitals, and you see what looks almost like a post box. It looks like almost like a mailbox with the opening to it. You can put anything you want in there, and it blocks it. You know, you can't reach in and get anything back, and you can get it out of your house that way. And so if you're thinking, wow, you know, I need to go through my med cupboard, I need to get rid of all of this stuff, they incinerate it. It has to be at a place that handles controlled substances, because it has to be done in a very specific manner. Now, a lot of places will have DEA drug take back days. They generally do them in the spring and in the fall. October, the weekend of October 24th or so was the last national one that the FDA sponsors. Those you can drive up to, drop your meds off by the bucket full. They get sealed, they get weighed, and they always have law enforcement there, you know, so nobody gets to shop after they drop them off, and they control those medications. So there's always the DEA drug take back days. So you have those national days, you have your local resources, you can put it in, you can run your zip code, and it will tell you where to go. But if you are like thinking, I'm going to have a house full for Thanksgiving, and I forgot that I have 60 Valium sitting here because I never used them. I don't want anybody to get into those, and I don't have time to run out. I'm busy making stuffing, you know. What do you do with that? You literally can take coffee grounds, and I'm just assuming we're all just healthy coffee drinkers. I'll work with my sister aside. She that's okay. I got that gene. She didn't. If you take your coffee grounds and pour those meds into it so that they break up, so they actually dissolve, you can then just throw them in the garbage. We don't encourage anyone to put meds down your toilet or down your sink. There's a reason for that. It isn't just like, that seems gross. That's not it. What happens is those meds will break down, and they will fill your sewer system and they get pumped out. They go into larger cleaning facilities, and they actually alter the water. If you put them in the sink, they can affect your water table. They can seep out and literally expose people and your environment to controlled medications and brain altering things, you know, through that. They can sit in the P valve in your sink and change. Yeah, it's gross. So coffee grounds, please, if you'd be so kind. Or package them up. You don't have to take your labels off. Nobody's going to come and find you. You don't have to worry about identity theft where it has your name and all that, you know, on your prescription bottles, because they just burn them up. They don't do anything else with that. So those are our home solutions. And for our wrapping it up, pick Dr. Swain's brain. I have, if there's any questions, I've been told I put out as many words as an auctioneer, so there might be a point that I tried to make that I made too fast. I'll apologize because I'm immersed in this, just like thinking everybody knew what a controlled substance was. So if we have any questions, I'm very happy to entertain them.
All right.
Awesome, Dr. Swain. So very informative,
Woo.
learned so very much. So that was wonderful. One of the first ones that we kind of have is, can people just have Narcan for emergencies? Can you just get a prescription and have it at home in case you need it?
So you can.
Or,
There's actually some new prescribing guidelines that say that if you're going to give somebody a controlled substance for more than 7 days, you should co-prescribe Narcan with it. So if you have controlled meds in your home, if you have prescriptions like that, you can just ask your provider and your insurance should cover it. On those days that there are the DEA days, they're often done in conjunction with free Narcan days, and a lot of systems will just hand it out. And the other is that you can ask, and Narcan is supposed to be an open prescription. So you can go to your pharmacist and you can say, I want to have Narcan in my home. And I carry it. I carry it in my I carry it in my purse because I don't want to leave it in my car for it to get too hot. But you know, I also have an emergency med kit and a tourniquet because, you know, a nurse, mask, can't help myself. But I also keep all of those things. So yes, you know, go through your physician or your pharmacies and ask for that. And a lot of times they just hand it out free. We would rather have 1,000 doses of Narcan out there that never get to be used than have a situation where you need one and you don't have one. Because again, as I've expressed, it isn't just those darn kids. It isn't the younger or the weak-willed or anything like that. It's our sweet little 76-year-old getting their knee replaced, not realizing that if I take this, this, and this, I might stop breathing. So Narcan would be great to have on hand. So go use those two resources. There's videos all over on YouTube and everything about how to use them, but it's very clearly says on the back. And if you can find someone's nose and push a button, you can use Narcan.
great. The next one was kind of about the recovery. You mentioned the 12-step program and the meds. Do you see better benefits if you do both together? I know you kind of lean more towards the medications, but what do you kind of see the best way to kind of manage that, or is it just by person?
I think I might not have expressed myself as clearly as I wanted to. Abstinence programs that don't use any medications do not have a very high success rate. Programs that use medication and therapy, you need counseling. You need to know why you did what you did. You need to understand how to undo things. You need to know what your triggers are, things to stay away from. When you combine that and allow the brain to heal so that you don't have that constant drive to take what you have been taking and can work on yourself, that's where your most success comes. So I would say it's a combination, but abstinence programs alone are not nearly as successful.
Right. And so usually kind of going off of that, usually if you do start the medication, do they usually also suggest the other as well?
Mostly it's mandatory. Any program I've seen
Great.
in Michigan, it's been mandatory. It's like, here's your medication. Who's your therapist?
Right.
Yeah.
Awesome.
Yeah. It isn't a one and all. Yeah. They work very well together.
So these last two I kind of have, they kind of go together.
Sure.
Kind of the first one is, how likely are people to relapse on opioids or prescription drugs?
It depends on the person and their disease process. So the longer the use, the harder to give it up. On average, people will need to seek treatment and a fresh start 3 to 5 times to be successful long term. But that's 3 to 5 times that we have kept them alive. If someone presents to the emergency department with an overdose, they are 80% likely to die within 7 days if we do not intervene. And if we can't get dead people into treatment, so we don't care how many times they return, but about 3 to 5 times until it can take. It is not a one size fits all. You know, it's not like, oh, look, these are glasses and I put them on now, I can see everything's perfect. It's it's breaking a lot of bad habits and asking for help and forgiveness and getting started over. But again, dead people can't get treated.
That's right. That's such a good point. We always get down on ourselves if we failed, but like you said, dead people can't be treated.
Yeah.
So
So here's the
continue
point.
to
Has
try,
anybody ever tried to lose weight?
Right.
Did it work? Like, did that one time? Because I can tell you that I try to lose weight every single day. So, pick your comparison. You can be addicted to, that Big Mac did look pretty dang good in that video. I'm just saying, and I don't even eat bread anymore. But, pick it. And we need to treat it with that same compassion that we have around any other addiction.
Yeah, that's such a great point. Wow. Yes, I love that. So kind of the last one I have is, if you know you have problems with prescription drugs, but you're getting ready to have a major surgery, maybe a joint or something like that, what should you do? What should you be aware of? Should you talk to your doctor about that?
Absolutely.
Are there other
Yeah.
drugs, maybe some
There
to
is.
avoid?
There's some really excellent options, and there's some very robust and mature healthcare systems actually have like inpatient addiction medicine services that will work on that. So if you previously had taken and had addiction issues with opioids and you want to stay away from opioids, I've had a lot of patients over the years that I've helped through this, even OB patients and things. They can use non-steroidal anti-inflammatory meds. There's some concern sometimes around healing, so they like to do that cautiously. They can do blocks. They can do additional block medicine. They can cautiously use an opioid that only they prescribe. So, like if day one you're going to be in a ton of pain, they can use something cautiously, and you don't have access to that when you leave. So, maybe you do have some morphine in the hospital that isn't going to immediately trigger everything to come back if you don't have access when you leave. A lot of people have done where they've said, you know what, I'd rather feel the pain than go through these concerns again. And they say, I'll take Motrin, I'll take Tylenol. Sometimes they'll give them a Toradol injection. The thing with the joints, again, is that the NSAIDs have been shown to delay healing at times. And so they're very cautious about using an NSAID, using a Motrin, any of those other anti-inflammatories, your Ultram, those kind of things like that. But be very open and honest and say, what can I do instead? If these people happen to be taking the methadone, buprenorphine, anything like that, they treat it. The thing is, if you don't treat pain, if you don't treat pain, it delays healing. And when you delay healing, you have more pain. And when you have more pain, you delay more healing. So you really need to work with your providers to make sure that you're able to function, but that you're not triggered. And maybe that is making a couple extra appointments in there. Maybe, they work to make sure they check your urine so that, you're going to be held accountable for what you're using and not using, and those kind of things. But if you don't talk to your provider about it, they'll have no opportunity to help make an individualized plan that will work for you. And the fact that I know about this as an RN up in Michigan means that it's happening everywhere. This is not news. There's a lot of articles and best practices around how do you control pain without using opioids if it's a patient's choice.
Great. Those are all the questions I had. So I'll hand it back to
Fantastic.
Kelly. And again, thank you so much.
My pleasure.
Great information today.
Oh, I hope so. And I'm fine with people having access to this the slide, to having the links, any of those kind of things, and if it sparks any kind of conversations that create additional safety. I'm just envisioning a whole lot of coffee grounds with little pills in it by Thanksgiving. These kind of things, just people forget about it. They really do. And if we're all more aware, we'll do a better job.
I agree. I really think it is an issue for awareness. Our grandmother, now that Jodi's let it out of the bag, um, was working for a doctor's office, and that was back in the 80s, we're going to say. Um, and when I went to her home, that was one of the things that I diligently worked at, was cleaning out the meds. the storage, well, I can't get that anymore. There's a reason for that, and it should be gone. And even if you look 10 years ago, as you were saying, we were prescribed more than what we probably needed for our pain. And yet we hold on to it and say, oh, well, I might, tweak my back, or I might twist my ankle, or, something might happen that I need this. And it really is important to get rid of them. They're not meant to last forever. And to get rid of them properly, I love the coffee grounds idea, but I would definitely have to go somewhere else and
You
get my
need to
coffee
borrow some.
grounds. I have been harassed here because I am not the coffee drinker, and my sister, honestly, Jodi, could IV the caffeine into her system through her coffee. My addiction is chocolate. I'm sure Kayla will attest to that. Everything goes with chocolate. Even when we made our edible Christmas tree with fruit yesterday, I did sneak some Snickers bars in there and suggested how some Reese's peanut butter cups could work. So please do understand that we all have these behaviors. And that's really what health education deals with, is your behaviors. The things that you feel rewarded for, those are the things you want to repeatedly do. Now, is that when I eat grapes, I'm all happy? Or is it when I get some substance that makes me happy, I stick with that? So we all have to work with that tendency for bad behaviors versus the ones that give us the healthy rewards. And it could be smoking, which we offer stop smoking programs. It could be with drug addictions. It could be relationship related. There are so many ways where we set ourselves up to not be as successful as we should. Whether it's weight loss or what it happens to be, we all have a struggle. So I do appreciate you bringing that up, Dr. Swain, that there shouldn't be any kind of
Stigma. Let's get rid of the stigma.
Get rid of the
We're all
stigma.
humans and we all struggle with something. Some of us carry it around and you can tell what it is, and some of us keep it hidden or in our large Yeti tumbler, whatever it is. We all struggle.
There you go. So we really do appreciate you joining us today, Dr.
Absolutely.
Swain. I love being able to brag on my sister and have her with us talking about an area of her expertise. If you noticed, I made sure when I did that spotlight information, she has more initials after her name than letters in her name. So I appreciate the fact that our mother gave her that photographic memory and she could share all of that with us today. For
A
all of you,
blessing and a curse.
yes, yes. For those of us joining us today, do remember, anyone who registers, we are sending out a little gift on behalf of a thank you that you are joining us. We're trying to stay engaged with you and keep you interested in things. So somebody will receive a little gift in the mail from us, and you will receive a survey after this. We love to get your feedback. What did you find interesting? What was helpful? What would you like to hear more of in the future? Please make sure to fill that out for us. All right. And again, just thank you for joining us. We're going to end our live Facebook right now. And thank you again very much, Dr. Swain and Kayla. I greatly appreciate your skills there, getting everything working